All right, let's scrub in. We're diving deep into critical care today, focusing on airway management and patient positioning.
Yeah, this is going to be good.
Our source is an Air Force training manual. It's pretty in-depth stuff.
You know what I find really interesting about this? It's not just for medical professionals. Anyone who wants to understand what happens in critical situations, like in an ICU, this is relevant.
It's like a backstage pass to the ICU, right? Learning how airways are managed, why positioning matters, it's all pretty crucial. And who knows, maybe this knowledge will come in handy someday, maybe even save a life.
You never know.
Okay, so let's start with the basics. Manual breathing devices, those masks and tubes we see on TV.
Right, so imagine someone can't breathe on their own. These devices are literally lifesavers. They get oxygen into the lungs manually.
So where do we start?
Let's keep it simple for now, with OPAs and NPAs, or a pharyngeal and nasopharyngeal airways.
OPAs and NPAs, okay, sounds a little intimidating,
Yeah.
but what's the difference?
It's all about where they go and who they're for. An OPA goes in the mouth, but only when the patient's unconscious. It keeps the tongue from blocking the airway.
Makes sense, you wouldn't want to try that on someone awake.
Definitely not. That's where the NPA comes in. It's designed for the nostril, so it's better for conscious patients.
Got it. So it's like choosing the right tool for the job.
Exactly. And speaking of the right tool, remember that trick for sizing an OPA? Something about the jaw.
Yeah. It was flanged to the angle of the jaw, right?
That's it. A simple mnemonic, but super important in critical care.
Simple but effective. All right, let's step it up a notch. What about the laryngeal mask airway? That sounds serious.
The LMA is definitely more advanced. Instead of just keeping the tongue out of the way, it forms a seal around the glottis, the opening to the trachea. So ventilation is more effective than a bag valve mask.
A bag valve, that's a BVM, right?
Yeah, exactly. Plus, the LMA is gentler on the stomach.
So less risk of complications.
You got it.
Yeah.
Speed is also key in emergencies, which is why we have the esophageal tracheocoma tube and the King tube.
The ETC and King tube, those are for like really urgent situations.
Especially in pre-hospital settings. They establish a temporary airway before more specialized care. They're kind of like first responders.
Wow, there's a whole arsenal of tools.
That's
Okay,
just-
I'm ready for the big leagues now. Endotracheal tubes, or ETTs. I always see those in medical dramas. They seem pretty crucial.
They are. ETTs are like the gold standard for securing an airway, especially when a patient needs help breathing with a ventilator. It's a clear, flexible tube that goes through the mouth or nose, all the way down into the trachea.
The manual goes into detail about all these features. Radiopaque lines, Murphy eyes. It seems pretty technical.
It might sound complicated, but it's not that bad. The radiopaque line helps us see the tube on an X-ray, making sure it's in the right place. Think of it as a GPS for your airway.
Okay, that's a good way to visualize it. And what about the Murphy eye?
Now that's interesting. The Murphy eye is a small hole near the tip of the tube. It acts as a backup airway if the main opening gets blocked, like a safety net.
Smart. So what about the cuff? That seems like the key to making the whole thing work.
You're right, the cuff is essential. It's like an inflatable balloon that seals the trachea, making sure air doesn't leak during ventilation.
Mm-hmm.
Plus, it protects the airway from aspiration. Think of it like a tiny, inflatable dam.
Okay, that helps me picture it. Now, the manual mentions different types of cuffs. Why so many?
It's all about tailoring the approach. Some cuffs spread the pressure out to reduce the risk of tracheal damage. Others provide a tighter seal, but need more careful monitoring.
Wow, so much thought goes into these seemingly simple devices. Then there are those specialty ETTs, uncuffed, subglottic suction, even double lumen tubes. It's a whole new world.
You're catching on quickly.
Yeah.
Each tube has its own purpose. Uncuffed tubes are mainly for kids. Subglottic suction tubes help prevent pneumonia by continuously removing secretions.
So they're like tiny cleaning crews?
Exactly. And the double lumen ETT. That one's pretty cool. It lets doctors ventilate each lung separately, crucial for certain lung conditions or surgeries.
Wow, 2 airways in 1 tube. That's mind-blowing. Let's shift gears now and talk about tracheostomy tubes. Those are for longer-term airway management, right? What makes them different?
The big difference is placement. A tracheostomy tube is surgically inserted directly into the trachea through an opening in the neck. It's usually for folks who need an airway for an extended period.
So it's a more permanent solution.
Not always permanent, but definitely longer term. And just like ETTs, tracheostomy tubes come in different forms: cuffed, uncuffed, even fenestrated.
Fenestrated. What does that even mean?
Picture a little window on the back wall of the tube. This allows air to slow up through the vocal cords when the cuff is deflated. Really helpful for assessing if a patient's ready to have the tube removed. It can even allow them to speak using a special valve.
Wait, so people with tracheostomies can talk?
They can. A speaking valve redirects airflow through the vocal cords when they exhale, enabling speech. It's pretty amazing.
That's incredible. But I bet there's a catch, something about the cuff.
You're sharp. The cuff has to be deflated for the speaking valve to work. Safety first. And while we're talking tubes, we should mention laryngectomy tubes. They're used after a laryngectomy, which is when the larynx is removed, often to treat laryngeal cancer.
So that tube becomes their only airway.
Yes, it's a permanent change.
Uh,
The stoma, the opening in the neck, becomes their new airway for breathing and speaking.
wow, that must be a big adjustment. Okay, on to something a bit more intense. Airway emergencies. The manual talks about tube obstructions, cuff leaks, and accidental extubation. Those sound scary.
They can be serious, but the key is recognizing the signs and acting quickly. Let's start with tube obstructions. They happen for all sorts of reasons. Kinks, cuff herniation, the tip getting pressed against the tracheal wall.
What about mucus plugging? That seems like it could be a problem.
Absolutely. Thick secretions can definitely cause an obstruction. You'd see increased pressure on the ventilator, decreased airflow, maybe even no breath sounds on one side.
So what do you do first if you think there's an obstruction?
You try repositioning the tube, maybe adjust the patient's head. If that doesn't work, use suction. Sometimes a little sterile saline helps loosen things up.
And if it's completely blocked?
That's when things get critical. You remove the airway right away and re-intubate. Sometimes you even need an emergency surgical airway.
Okay, that's intense. What about cuff leaks? What causes those?
Cuff leaks can be caused by problems with the pilot balloon, the pilot tube, or the cuff itself. The balloon could have a leak. Or the pilot tube, which connects the balloon to the cuff, might disconnect. And of course, the cuff itself can rupture.
So many things to watch out for. How do you even know if there's a leak?
You might notice a drop in pressure on the ventilator, decreased airflow, even hear air leaking around the tube. And here's a funny one. If the patient suddenly starts talking to you, that's a pretty good sign.
Good point. What do you do if you find a leak?
First, figure out where it's coming from. Then tell the doctor immediately and figure out the next steps together. Manage the leak until the patient can be extubated or re-intubated with a special catheter.
Got it. Okay, last one. Accidental extubation. That sounds terrifying. What causes that to happen?
It can happen for a few reasons. Sometimes it's from inadequate sedation, maybe during a sedation holiday, or when we're letting the patient breathe on their own for a bit. Other times it's related to patient restraints, equipment issues, or even something as simple as a beard.
Wait, really? Facial hair can cause that?
Yeah, it can make it harder to secure the tube. Patient factors can also increase the risk. Think breathlessness, agitation, strong cough reflex.
Makes sense. So what happens if someone is accidentally extubated?
It can be pretty serious. Laryngospasm, where the vocal cords spasm shut, and laryngeal edema, swelling around the vocal cords, are both immediate concerns.
Both of those can block the airway, right?
Exactly. That can lead to hypoxia, low blood oxygen, and potentially respiratory failure. There's also a risk of aspiration, where stomach contents get into the lungs, which can cause pneumonia. In the worst-case scenario, it can be fatal.
That's really scary. Okay, let's talk about repositioning those endotracheal tubes. When and why do you have to do that?
Repositioning an ETT is pretty common in the ICU. It might be necessary if the tube moves, causing uneven breath sounds or chest movement. Sometimes a chest X-ray shows it's not in the best position.
So how do you reposition it?
First, you want to position the patient correctly, usually with the head of the bed elevated if their condition allows it. Then you check the tube's placement, looking at the numbered markings.
And then you hyperoxygenate, right? Like with other procedures.
Exactly. We want to make sure they have plenty of oxygen before we do anything to their airway. Then suction the trachea and mouth to remove any secretions that could cause problems.
Okay, so the patient's prepped. What's next?
Now comes the tricky part. Carefully loosen the tape securing the tube, but never let go. Maintain control of the airway at all times.
Makes sense. Wouldn't want it slipping out. Then what?
Gently deflate the cuff, just enough to create a slight leak. That makes it easier to move. Then advance or retract the tube as needed, reinflate the cuff, check the cuff pressure, and securely retape it in place.
Precision is key here.
Absolutely. And don't forget documentation. Record the new placement and depth, and always get a follow-up chest X-ray to confirm the final position.
Wow, this has been fascinating. From simple OPAs and NPAs to repositioning and ETT, keeping those airways open is a complex process.
And we've only just scratched the surface. Stay tuned, because we're going even deeper into critical care techniques, like extubation and artificial airway care, in the next part of our deep dive.
I can't wait.
Welcome back. We're diving deeper into the world of critical care.
We've covered a lot already. Manual breathing devices, repositioning ETTs. It's been a whirlwind.
Now, let's talk about a procedure that's a big step toward recovery. Extubation. Taking that endotracheal tube out, letting the patient breathe on their own again.
It's like a symbol of progress.
You got it? But it's not as simple as just pulling the tube out. There's a lot of planning and preparation before we even consider it. The manual really stresses assessing the patient's readiness, understanding the risks.
So it's not just about whether they can breathe, but if they can breathe well enough on their own.
Exactly. We have to make sure their respiratory muscles are strong enough, that their cough is effective, and that they can keep their airway open.
So what are some of the key things you look for to see if a patient's ready for extubation?
Well, there's MIP, maximum inspiratory pressure. It's basically a strength test for those breathing muscles. A good MIP tells us those muscles are ready to work.
And what about tidal volume? I remember that from when we were talking about manual breathing devices.
Right. Tidal volume is the amount of air inhaled and exhaled with each breath. We like to see a good tidal volume before extubation. And then there's vital capacity, the maximum amount of air a person can exhale after a deep breath.
Got it. So bigger breath, better chance of extubation. What else?
Well, of course, they need to be awake, alert, and able to follow instructions. We want them to be active participants in this process.
So mental readiness is just as important as physical readiness. They need to be engaged.
Absolutely. It's a team effort. Now, the manual also highlights some of the things that can go wrong during extubation.
Yeah, I was wondering about the risks. What are some of the things that could happen?
One of the scariest is laryngospasm. That's when the vocal cords suddenly spasm shut.
Oh, wow, that sounds scary.
It can be. It can partially or even completely block the airway. Then there's laryngeal edema, which is swelling of the tissues around the vocal cords, and that can also cause obstruction.
And if the airway's blocked, the patient can't get oxygen.
Exactly. It can lead to some pretty serious complications. Hypoxemia, which is low blood oxygen, is a major concern. In severe cases, it can even lead to respiratory failure, cardiac arrest, even death.
That really highlights the importance of being prepared for anything during extubation, having the right equipment and medications ready.
Absolutely. We need to be ready to intervene quickly. Suction equipment, oxygen, medications to reduce swelling, it all needs to be there.
So extubation is this balance between giving the patient back their natural breathing and being prepared to jump in if things go wrong.
That's a great way to put it. Okay, let's walk through the actual extubation process. What happens?
Yeah, I'm ready for the step-by-step.
First, we get the patient ready. We explain what's going to happen, answer any questions, address any anxieties. Then we position them comfortably, usually with the head of the bed elevated, unless their condition prevents that.
Makes sense. And then hyperoxygenation is next, right? Like we talked about before.
Yep. We want to give them a boost of oxygen before we take the tube out, just in case there are any breathing problems afterward.
Okay, so they're prepped, they've got plenty of oxygen. What's next?
This is the big moment. We remove the securing device carefully, but keep a firm grip on the tube. We ask the patient to take a deep breath, then quickly deflate the cuff and gently remove the tube as they exhale.
It all happens so fast, and then you switch them over to an oxygen delivery device.
Exactly. Usually a high-flow nasal cannula. We might also use a face mask or a face tent, depending on what the patient needs.
And then you watch them like a hawk. The post-extubation assessment is just as important as the procedure itself, right?
Absolutely. We monitor them closely for any signs of trouble breathing, like stridor, that high-pitched sound that means the airway is narrowing, or wheezing, a whistling sound that suggests bronchospasm.
And you're listening for these sounds with your stethoscope.
You bet. Plus, we're watching their breathing pattern, heart rate, blood pressure, and oxygen saturation. Any little change could mean a problem.
It's like being a detective, looking for any clues that the patient might be struggling.
That's a great way to put it. We have to be ready to act quickly if anything goes wrong.
Okay, let's shift gears now and talk about caring for artificial airways, especially tracheostomy tubes. The manual stresses how important it is to keep those airways clear and prevent infection.
That's a really important point. Tracheostomy care is all about maintaining a clean stoma, the opening in the neck, and making sure the tube is working properly. It's like a daily cleaning routine.
So walk me through tracheostomy care. What does that look like?
First, we gather everything we need. Gloves, sterile solutions, brushes, gauze. Everything has to be clean and sterile. Then, we explain the procedure to the patient, make sure they understand what's happening and why it's important. We want them to be comfortable. We usually position them in a semi-Fowler's position unless their condition dictates otherwise.
Got it. And then suctioning is the first step.
Exactly. We suction the tracheostomy tube to clear out any secretions.
And then the inner cannula.
Right, the inner cannula is a removable part of the tube that needs regular cleaning. If it's disposable, we just swap it out. If it's reusable, we carefully clean it with a brush and a sterile solution.
Okay, so the inner cannula is clean. What about the stoma itself?
We're very careful with the stoma. We use sterile cotton-tipped applicators and gauze pads soaked in a mild cleansing solution. We just dab and clean gently, no scrubbing. We don't want to irritate the skin around the stoma.
And you're also looking for any signs of infection, right? Redness, swelling, anything unusual.
Absolutely. We let the doctor know right away if we see anything concerning. Once the stoma and inner cannula are clean, we put on a fresh dressing, secure the tube, and make sure everything is snug but not too tight.
And then you check on the patient to make sure they're doing okay.
Always. We monitor their breathing, oxygen saturation, heart rate, and blood pressure. We want to make sure they're comfortable and stable.
Tracheostomy care sounds pretty involved, but it's obviously important to prevent complications and keep the patient on the road to recovery.
It really is. Okay, now let's talk about airway suctioning.
Okay, suctioning. The manual mentions two types. Nasotracheal suctioning, where the catheter is in the nose, and artificial airway suctioning, where you suction through a tracheostomy tube or ETT. What's the difference?
Both techniques are for removing secretions and keeping the airway clear, but the method depends on what kind of airway the patient has.
So how do you know when a patient needs suctioning?
Sometimes it's obvious, you can actually see the secretions.
Yeah.
Other times you might notice changes in the ventilator readings. Or when listening to breath sounds, you might hear coarse sounds that suggest secretions are present.
And sometimes vital signs or blood gases can indicate the need for suctioning, right?
Yep. A drop in oxygen saturation or an increase in carbon dioxide can be red flags. And sometimes the patient will let you know. They might get restless or agitated because they're having trouble breathing.
So are there ever times when you shouldn't suction?
There are a few absolute contraindications, meaning you absolutely cannot suction. One is epiglottitis, which is severe inflammation of the epiglottis, that flap of tissue that covers the windpipe when you swallow.
I can see why suctioning would make that worse.
Yeah, it could cause a complete airway obstruction. We also need to be extra careful with things like nosebleeds, head or neck injuries, and bleeding disorders.
So you really have to consider each patient's situation carefully.
Absolutely.
Yeah.
The benefits of suctioning have to outweigh the risks. The manual also talks about some of the hazards associated with suctioning.
Oh, yeah, like what? What can go wrong?
The biggest concern is hypoxia, low blood oxygen levels. Since suctioning removes air along with secretions, it can temporarily lower oxygen levels.
Okay, yeah, that makes sense.
We also have to watch out for atelectasis, which is the collapse of tiny air sacs in the lungs.
Yeah.
That can happen if too much air is removed.
Yeah.
And of course, there's always the risk of damaging the airway tissues if you're not careful with the catheter or the suction pressure.
So gentle technique and the right equipment are really important.
You got it. Let's talk about the two main suctioning techniques now. Open and closed systems. Open suctioning is less common these days. It involves a sterile catheter connected to a suction source.
And the closed system is the one with the inline suction catheter that stays connected to the ventilator?
Yep. The closed system is more self-contained, so there's less risk of contamination.
And it helps maintain positive pressure in the lungs, right? We talked about that earlier.
Exactly. That's why closed suctioning is usually preferred, especially for patients on ventilators.
So even though there are two different systems, are the basic steps of suctioning pretty much the same?
Pretty much. You always check your equipment, make sure you have the right size catheter, a working suction source, and your protective gear. Then you explain the procedure to the patient and position them properly, and hyperoxygenation is key before you start.
Okay, got it. And then you insert the catheter and apply suction.
Yes, but how deep you insert the catheter and how long you suction depends on the patient and how much secretion there is. We're always careful not to be too forceful or suction for too long. We don't want to cause any damage or lower their oxygen too much.
Makes sense. Now, the manual mentions something called a mini BL. What is that?
A mini BL, or mini bronchoalveolar lavage, is a way to get a sample of lung secretions without using a bronchoscope. We instill a little bit of sterile saline into the lungs and then suction it back out.
So it's a less invasive way to diagnose things like pneumonia.
Exactly.
Wow, we've covered so much ground today. We've talked about extubation, tracheostomy care, and suctioning. It's amazing how much goes into managing the airway.
It really is. And there's still more to come. In the next part, we'll be talking about end-tidal capnography, which is a way to monitor the patient's breathing, And we'll also discuss the importance of patient positioning.
I'm ready for more. And we're back. It's the final part of our critical care deep dive.
It's been quite a journey,
I feel like I've learned a whole new language just listening to all this.
a lot to take in.
But I'm ready for more. Today, it's end tidal capnography and patient positioning in the ICU.
Two really important topics.
They often get overlooked, but I'm guessing they make a huge difference for patients.
You bet they do. They can be game changers.
Well, let's dive in then. End tidal capnography. It's a mouthful. What is it, and why is it so important?
Imagine it like a window into your patient's breathing. End-tidal capnography, at TCO2 for short, measures the carbon dioxide in each breath they exhale.
Okay, so the CO2 that's released from the lungs, why is that so important?
It's all about gas exchange. A TCO2 tells us how well the lungs are getting rid of carbon dioxide. High levels, maybe they're not ventilating properly. Low levels, maybe they're breathing too fast and getting rid of too much CO2.
So it's like a warning system, letting you know if there's a breathing problem before it gets really serious.
That's a great way to think about it. But it's not just about the numbers. CO2 monitoring also gives us a waveform, a visual representation of their breathing.
Now we're talking waveforms. What do they look like? What can you learn from them?
Picture rolling hills on a monitor. That's what a normal CO2 waveform looks like. Each hill represents the CO2 being exhaled, and the shape tells us about the timing and efficiency of each breath.
So you can actually see the patient's breathing pattern on the screen.
Yep. And if something's off with that pattern, it can be a big red flag, like a sudden drop could mean a leak in the breathing circuit.
It's like a detective story, but with breathing. The manual also mentions using TCO2 during CPR.
Oh yeah, it's super important for that. It lets us see if chest compressions are working, and even more importantly, if the heart starts beating again.
Wow, so you can tell if those compressions are actually doing their job. That's pretty incredible.
It is. Okay, let's zoom out a bit now and talk about monitoring patients in the ICU in general. There's a lot to keep track of.
That's for sure. The manual mentions oxygen levels, breathing patterns, brain activity, kidney function, even liver function. It's overwhelming.
It's a lot, but think of it like a puzzle. You need all the pieces to get the full picture of what's happening with the patient.
So each piece of information tells you about a different part of the body, and together they give you a complete picture of the patient's health.
Exactly. We've already talked about CO2, but what about other aspects of respiratory monitoring?
Well, there's oxygen saturation. Right, you use a pulse oximeter for that.
Right, that little device that clips on your fingertip. It gives us an estimate of how much oxygen is in the blood.
So the higher the number, the better.
Yep. We also do arterial blood gases, or ABGs, which give us a more detailed look at oxygen and carbon dioxide levels in the blood. That helps us make sure the ventilator settings are just right.
Okay, what about monitoring ventilation?
For that, we look at the respiratory rate, how many breaths per minute, and tidal volume, the amount of air moved with each breath.
So it's all about making sure the lungs are doing their job, getting enough air in and out.
Exactly. Neurologic monitoring is super important too, especially for patients with brain injuries.
The manual talks about intracranial pressure monitoring and the Glasgow Coma Scale.
Right, so intracranial pressure, or ICP, is the pressure inside the skull. High ICP can be really dangerous, so we sometimes use a special monitor to measure it directly.
And the Glasgow Coma Scale, that's for assessing consciousness, right?
Yep. It looks at things like eye-opening, verbal responses, and motor responses. A higher score means the patient is more awake and responsive. It helps us track how severe a brain injury is.
Got it. Now, what about the kidneys? How do you keep tabs on their function?
We check blood levels of BUN and creatinine, which are waste products that build up when the kidneys aren't working well. We also monitor urine output.
Making sure those filters are doing their job. And what about the liver?
We monitor liver enzymes through blood tests. If the levels are high, it could mean there's liver damage.
So by monitoring all these different systems, you can tailor the treatment to each patient.
Exactly. And to get a broader picture of their overall condition, we use these things called global monitoring indices.
Global monitoring indices, those sound pretty serious.
Think of them as scoring systems that look at many different factors to determine how sick a patient is and their risk of dying.
So it's like a comprehensive assessment.
Exactly. One example is the APACE-2 score, which stands for Acute Physiology and Chronic Health Evaluation. It considers age, vital signs, lab results, even pre-existing conditions.
And a higher score means?
The patient is sicker and has a higher risk of, well, not surviving. These indices help us figure out the best treatment plan.
It's amazing how much you can learn from all these monitoring tools.
It really is. Okay, let's finish up by talking about patient positioning.
Yes. I've always wondered why that's such a big deal in the ICU.
Positioning is all about helping the patient breathe better, preventing complications, and keeping them comfortable. We use gravity to our advantage.
So more than just comfort, it's about giving them the best chance of recovery.
Exactly. The manual talks about several positions that are used in critical care. A common one is Fowler's position, where the head of the bed is raised.
Oh yeah, sitting up in bed. Why is that helpful?
It makes it easier for them to breathe. It's like giving their lungs more room to expand.
Okay, that makes sense. What about lying on their side?
That's called lateral positioning. It helps drain secretions from the lungs, especially for patients who can't cough well. And it can be really helpful for patients with lung disease that affects only one side.
So it's strategic positioning to help the lungs work better? What about lying on their stomach? That seems a little counterintuitive.
That's called prone positioning, and it can actually be really helpful for patients with severe ARDS. It helps open up collapsed air sacs in the lungs.
So even though it might not be comfortable, it can help them get more oxygen.
Exactly. And then there's the Trendelenburg position, where the head is lower than the feet. It can help with low blood pressure.
But the manual said it can also cause problems, right?
You're right, it can make breathing harder in some patients.
So choosing the right position is a balancing act.
It is. You have to consider each patient's situation and what will help them the most. Well, that wraps up our deep dive into critical care.
It's been an incredible journey. We've covered so much. Airway management, monitoring tools, patient positioning. It's mind-blowing how much goes into caring for critically ill patients.
It's a complex field, but incredibly rewarding.
Absolutely. I have a whole new appreciation for what healthcare professionals do every day in the ICU.
They are amazing.
I think the big takeaway for me is that everything in critical care is about helping the patient heal.
That's a great way to put it. From keeping their airway open to monitoring their organs and making sure they're comfortable, it's all about giving them the best chance of recovery.
So for those of you who are interested in medicine, this deep dive is just the beginning. Keep exploring. And for everyone else, we hope you've learned something new and gained a better understanding of this amazing field.
Thanks for joining us.
And until next time, keep those brains curious.